There we go. Hi, this is Lisa from Health Facilities Planning. If anyone doesn't know me, we are a consulting firm that has been working with the consortium on a lot of the data. So
thank you. Mr. Novelli?
It's Jim Novelli from Discovery Behavioral Healthcare.
Cool. Hey, one of the things I forgot to mention is if you guys are chasing any interesting grants or any uninteresting grants, let us know that too when you introduce yourselves. Matt, ready?
Sure.
Hi, Matt Reddy. I'm
Matt
one of
Reddy.
the hospital commissioners.
Nice to have you here. Cherish?
I'm Cherish Cronmiller. I'm the Executive Director at OLICAP, your community action agency for Jefferson and Clallam counties.
Thank you. Good to have you here. Chief McKern?
McKern, Coolstein Fire Rescue Fire Chief.
Brian Richardson?
Hello, Brian Richardson with Dove House Recovery Cafe.
Nat Jacob?
Hi, Nat Jacob with the Public Defender's Office. And when Lori introduced Matt, I thought she asked if Nat was ready. So sorry about that.
And you are ready?
Yes.
Yes, you are. Chief Server?
Hi, how are you?
Good.
I'm multitasking here. Troy Serber with Port Townsend Police Department.
Glad he's multitasking. Let's see. How about Ford? Ford, thank you for dressing up for us.
Oh, yeah. Ford Kessler, Director of Beacon of Hope Safe Harbor and Drug Court and Family Therapeutic Court Administrator.
Thank you. Chief Knoll?
Would you call me?
Sorry, Sheriff Knoll.
Oh, thank you. I thought you
That wasn't recorded, was it?
I'm sorry, I was trying to be funny. Joe Knoll, Jefferson County Sheriff.
Good to have you here. Denise?
Denise Banker, Community Prevention and Wellness Initiative Program Director.
Good to have you here. Thanks for coming. Adam, of course, I hit him just as he's trying to take a sip.
Hi. Hey, Adam York, Jefferson Healthcare Population Health Data Analyst.
Thank you. I'm glad you're here. Jake Davidson.
Hello, Jake Davidson, Jefferson Healthcare.
And Chief Black. Chief, you may be speaking, but we can't hear you, but we can see the Fire and Rescue logo. We don't actually see you, but we're happy you're here. Everybody's eager to meet you. Okay, I'll go on to Dunya.
Hey everyone, Dunya Fo, Jefferson Healthcare.
Hi, Dunya. Good to have you here. And I just see that Chief Black has said he is here and can hear and see us. Okay, I'm going to start sharing the screen and give you guys. Go ahead, Joe.
Yeah, I had a comment I wanted to make. This week I've been a judge, I guess you'd say, for WASPIC grants for Navigator. And I just wanted to say that today we heard from a large metropolitan agency that was asking for a substantial amount of money. And one thing that they said that was kind of disheartening was that by having the Navigator program, they could start making connections with their service providers in their area. And I thought that was really strange. And I was thinking how we've been doing this for a long time. So I just wanted to, I guess, thank everybody. And I just felt like how far we were ahead from this city that I would have thought would have everything and know everything. So I really,
that's really good to know.
Yeah, and a lot of that I think goes to you and John for spurring us along. But just wanted to share that. I was proud to be the Jefferson Countyan today.
A Jefferson Countyan. Well, me too. Thank you. Anyone else before I flip over to the presentation? Okay. You guys can see a slide? Is that true? Yes.
Yep, we can see.
Oh, thank you. Thank you. Okay. First of all, we wanted to welcome some new folks here. We've got Cherish Cromiller from OLICAP, Nat Jacob from the Public Defender's Office, Chief McKern from Quilcene Fire, and Chief Brett Black from East Jefferson Fire and Rescue. And Chief Black, I may have misspelled your Brett, and I apologize. Wanted to quickly note that the therapeutic drug court had 2 graduates. This was actually 2 weeks ago, and I think 2 more have graduated just as of today. We'll get those into the next presentation. But this is Lindsay Shaw and Travis Short, and they graduated on the 3rd. So if you see them around, congratulate them. Today we're going to go through Jefferson Healthcare is going to give us an overview, Jake Davidson, of their behavioral health service. And then we're going to leap into a data discussion that Lisa Grundl will be leading. We will very quickly fly through an overview of just what's getting done on all these projects we have going. And John will give a bit of an update on the CHATA CHIP effort. And so we'll just jump in. So I'm looking to see where I have Jake Davidson.
Somewhere.
Here you are. Okay, great. So I'll put up your first slide and you just tell me when you want me to move to the next one.
Awesome. Great. Well, hi everyone. Jake Davidson. I am currently the executive director of the medical group. So I oversee all of most of our outpatient clinics. And so, yeah, next slide, please, Lori. So wanted to hit on the 2 kind of things that we have done a lot of work around over the last couple of years. So the first is integrated behavioral health, and integrated, that means within our primary care clinics. So about 2 years ago, we actually rolled it out. And I think we've done a lot of different things over the last 10 years or so. John probably knows better, but and just didn't have much traction. And so we did have a couple LICSWs that weren't really able to work in patients in a timely manner, and had patients that they had been seeing for multiple years. And so we kind of looked at different programs or different options of kind of integration out there, and landed at that time actually on the UW Ames model. But we did kind of we did the free version, if you will. And actually about a year ago, with Dunya's support, actually Dunya doing most of it, we got the Primera grant that they put out for, I think it was a couple states, but in conjunction with UW's AIM program, to 10 different cohorts, and there was some money attached to it, but more importantly, was just support in doing this work. And so we currently have 3 LICSWs that work out of all 5 of our primary care clinics, including our Quilcene clinic in South County. And then we have Dr. Heastan and Ann Kuman, so both key to this program of providing support to the LICSWs and all of our patients. So went through the whole process with UW. We were one of the 9 all small rural facilities. We were and still are much further along than the other 9 because of the work we've done beforehand. We currently, actually, the coolest thing for us that came out of this was using their registry. So the ability to track patients that our LICSWs have been seeing, the ability to follow up with them, see if they haven't followed up in a certain amount of time, much more metrics. And actually, I think I saw Adam on the call. Adam's using our registry to pull many more metrics along with our EHR Epic and looking at different things to just see how this is affecting the behavioral health of our patients. So that's pretty exciting. Also, just kind of better understanding, kind of what are the UW AIMS kind of standards and getting to them. We do monthly check-in, or I guess bi-weekly check-ins with the behavioral health team, all of them together. There's weekly site consults. So anybody that's not doing better on this program, our Dr. Heasan or Ann Kuman, our psych RMP, basically get involved with our LICSWs to look at different options. Much more bidirectional communication between the behavioral health team and the primary care team. Go ahead and hit the next slide, Lori. So you can see some of the metrics on the left and then, or sorry, on the right, and then on the left is just kind of how it works. And so we have your standard primary care providers, which, if we didn't have any behavioral health support, is trying to do as best as they can to provide support. Now we add what we call the case managers, or LICSWs, that see the patients. And I think right now our registry is at about 160 of our primary care patients are seeing one of our LICSWs. And then through the registry and the weekly consult meetings, our LICSWs meet with Dr. Heasan and Ann to, like I said, talk through that and see where do we need to get them to a higher level of care? Is there something to do better at? And so really starting to use the metrics to see if what we're doing through this program is working. So a little bit about UW AIMS is it's really using the PHQ-9 and the GAD-7 to treat the target. And so using CBT is our main modality right now, but looking to add a couple more, PST, which UW offers. So our team's going through that training here shortly, but to really track how folks are doing in the much more brief sessions, and hopefully in over a couple months we will see those scores reduce and then put them in what we call relapse prevention. So it's been great. Our primary care providers have really appreciated having this, and we've really created a lot of workflows to create low barriers to both our patients and our primary care folks to getting them in with our behavioral health team. So that's a little bit about our integrated behavioral health. I don't know, I'm more than happy to open up for questions, but then the next is just our MAT and substance use disorder. So about the same time, we put out an offer to all of our primary care providers. We've got about 30 of them to go through MAT training and to eventually hopefully get MAT waived. We didn't force it on any of them. Felt that it was, an important option for them to either want to or not to. At that time, I think when we first finished, we had about 18 providers that were waived. Right now we're at 15. And actually we just had a wave of new PCPs that we just offered it to again. So we're hoping to increase that number as well. Currently, we're at about 30 patients. Again, Adam is using his magic to help us track that because, we offer this anywhere from South County, Port Ludlow, and up here in Port Townsend as well. So just wanting to make sure we have accurate numbers there. But yeah, about 30. At our highest, I think we had 65, upwards of 70. We are part of a hub and spoke with Peninsula Community Health, and Dr. Bruce is kind of our expert that our providers can go to if they have any questions. And then we also get funding for that for a MAT coordinator. So unfortunately, we lost our MAT coordinator to the ED, which is great for her to then be able to let patients there know what we have to offer, and are looking to replace her ASAP. And actually this position, Dunya is helping to have as well with her team. So a little bit about what we offer on this opioid use disorder front.
Sorry. So are there any questions from folks about Jefferson Healthcare's program? Go ahead, Sheriff Null.
Yeah, I had a couple of questions on the slide that showed the provide. Yeah, maybe you said this, but I missed it. But what is the registry?
Yeah, so the registry is actually, I think, the coolest piece. My team probably disagrees, but it is a way for us to, when anybody basically initiates or starts with this program with one of our LICSWs, we put them in the registry, and the registry actually helps guide a lot of the work we do in the sense of, you know, that if this person hasn't seen them in a certain amount of time, it notifies us. If one of our MDs or ARMPs is going through one of our LICSW's registry and said, this is an interesting one that I want to talk about, they can actually flag it. The LICSWs can actually flag it as well, so that when they meet weekly, they can review that case and decide, you know, if there's something to change. So yeah, the registry is awesome. And then we actually track monthly numbers with AIMS to review with all of our behavioral health team and UW to look at certain metrics and say, you know, is there something that we need to change or do better? So it's actually been a game changer.
And then I actually had a couple, and then just I'm trying to understand this model, I guess. And like if I went to my doctor, who is part of Jefferson Healthcare, and I was having a behavioral health issue, would he refer me to that, or would I guess I'm wondering how that would present.
So for this program is I mean we can just about, so the main ones honestly are depression and anxiety. That's what works the best with this program. But we have seen, you know, we've seen all kinds of different diagnoses. But yes, your PCP would say, hey, I want to get you in with one of our LICSWs. And, you know, in the perfect world, we do a warm handoff. They are pretty busy right now, but we do have time carved out where we would actually have them come to your room before you get checked out to have your PCP say, hey, here's our LICSW that I'd like to set you up with. So that warm handoff is best practice. So in the perfect world, that's what we would do. But yes, your PCP knows all about this and would refer you to them.
Would there be referrals like to Discovery Behavioral Health?
Yeah, so depending on what, you know, our team feels is appropriate for them to see versus what like our MD or ARP feel they would see, yeah, we would refer outside on definitely many different cases, but yes, we would do that if needed.
Okay, and then I sorry to be dominating, but with the MAT program, is there counseling that goes along with that as well, or do they? We should. That's been one challenge we've had is getting our patients in to do that as well. Yeah, it should go together. Okay.
No, it's honestly nice to talk about something other than COVID right now. Or I should specify COVID vaccine. That's been my life over the last three weeks. So.
When are those coming? I'm just kidding. Don't answer.
Oh, actually,
don't answer that. No, I'm just kidding.
No, we're the 15th. I'm planning to start vaccinating on the 16th. So.
Right.
Okay.
Well, we're lucky we got you before that. That started rolling out.
Yeah. Well, I feel bad. I was supposed to be here last month, so I apologize.
Is there any other questions? Jay?
I think this is John, and I think I know the answer to this, but just it might help everybody else. So kind of a follow-up on Sheriff Knoll's question. The referrals are made based on the screening tests that you do, the GAD and the PHQ tests that you do, and if the patient's above a certain level, then they get referred. Is that kind of how that works?
Yeah, mostly. So part of the work we did was identifying what visits to a PCP should we be doing a PHQ-9. And so a lot of your wellness visits, your annuals, we're doing them because, you know, just because somebody's not there for behavioral health issues doesn't mean that they don't have it. And so, or have them. And so we wanted to screen a lot more. And so, yeah, we do it during those screenings, but yeah, you know, if the PCP senses something's up, you know, it's not actually just even those screenings, they can do a referral. And, you know, anyone that knows referrals are a nightmare. We actually don't hold up scheduling for a referral process. We'll just get you in.
That's good to know. Anyone else? Okay, then I'm going to move it. Thank you so much, Jake. We appreciate your time and presentation and what we now know. Thank you, Sheriff Knoll, for all of your questions. Moving into the data discussion, I'm going to turn it over to Lisa Grundl.
Hi. Great. Well, thank you everybody for participating in all our interviews this week. Many of you have been on the phone with me, and I just wanted to say thanks again. And we are going to start this discussion just kind of trying to lay the groundwork for why we are asking these questions again. So we've been talking a lot about data, and there are several reasons that we need to get our arms around this data. One is related to just the HRSA grant and the fact that we need to ensure compliance with those reporting requirements and figuring out how the data we're collecting from all of you matches what they need. One example is screening. We need to give them numbers on screening. They want some background on that and some demographics related to that. So trying to figure out what we can give them as far as some kind of standardized screening numbers. We also, of course, want to continue to evaluate the services that are needed, potential volumes for services that are needed in the community. And we've done some talking lately about just being able to establish a really good baseline so that as we move forward with the grant or just with projects in general in Jefferson County, that we know what the impact of those measures are. So, or not of the measures, of the activities that we've implemented are. And not just clinical outcomes, but of course, process outcomes. Are we doing what we said we were going to do? Has it changed people's attitudes about alcohol and drug use in the community? Have we addressed some issues around stigma? So we're trying to figure out some of those baseline measures as well as not duplicating. And we'll talk about that more, things that are already going on in the community. And then the final thing that we wanted to talk about is there a way to standardize some of these buckets of data that we have? We're getting a lot of data from different first responders and the hospital and trying to figure out, is there a way that we can standardize how they're gathered or at least how we classify them? And so that's kind of the purpose of the calls we've been making in our discussion today. And we know we're not going to answer all these questions today, but we thought we wanted to kind of lay the groundwork, see, get people's reactions for some of these subjects and see how to move forward. So next slide, Laurie. So again, key questions. Why are we trying to what are we trying to establish with the data? John always brings us back to this. We want to make sure we're not just doing data for the fun of data, which I definitely can get caught up in. So making sure we know what we're trying to establish. We went over some of those questions in the last slide. The other is, what of this data is worthwhile and important for the activities that we are trying to move forward, or the grant requirements, or just for the community in general? What data do we need to focus on? And then how can we establish a firm baseline? We just kind of talked about that. How do we measure that over time? Can we move to standardization? And then one of the big questions is, we've been really focused on, apples to apples, duplication, and is duplication just okay? This is one of the questions we want to talk about. Does it tell its own story that we have so much duplication? That we have duplication as far as both patients being seen at different places, patients having different conditions, patients double counting in mental health and SUD services, those kinds of things. Like, maybe that's okay. Maybe that tells its own story, that this is really a community-wide issue, and that we are going to see these patients in different places, and they are going to face multiple issues. One of the things that when I was talking to people that kept coming up was, it's not, there wasn't like a focus on SUD and behavioral health. It was housing and economics and all these things that we know impacts people's health in the community. And so just, again, duplication seems to be a thing, and deciding how we handle that with the data and how we process that. So context-wise, I just pulled together some data because of what I just said around the focus being so much bigger than just drug use or mental health, but much bigger than that as far as just the whole impact of social determinants of health. And somebody else, so I won't take credit for this, in our group had raised the Robert Johnson model as something that we need to keep our eye on when we're thinking about what makes a difference for people in the community. And really the most important thing on this is to look at these buckets of what impacts health outcomes, and clinical care is 20% of that. And health behaviors is 30%, and social economic factors is 40%. So when we're focusing on what makes a difference, just that whole, which all of you, I'm sure, understand that, but it was a really good, I think, set the context for what we think about when we think about data, and how we see if we're moving the needle has a lot to do with what we're looking at. So if you want to go to the next one, Lori. So I just ran some of this data. So the Robert Wood Johnson Foundation has county health rankings where they look at each of these elements that we just talked about, health outcomes and health factors, and how your county ranks. And I thought it was interesting because of a lot of your focus on not losing track of the socioeconomic things that impact people's lives, is that Jefferson County, that is the place when you look at health factors that you rank the lowest in the state. Not the lowest, but for yourself, you rank the lowest. You're doing pretty good on some of these other issues like primary care provider ratios around clinical care. You're doing pretty well. And then when you look at some of the social and economic factors, that's where there's some issues that need to be addressed in order to really change those health outcomes. And so when you look at the next slide, I went to, there's some, oh no, this is still county data. This is, again, from the county health rankings. They roll those up to those degrees, and then they have for socioeconomic, these are the things that get measured in that ranking. And so you can see education, unemployment, children in poverty, income inequality, children in single parent households, all those things are higher in Jefferson County than they are statewide. And so, or worse, I shouldn't say higher, because it depends on whether the number is lower or higher. So it's, they're doing worse than the state. And so that was just kind of one of those indicators of just validating what these issues that people have been raising in these calls about how important some of those issues are for us to deal with while we're thinking about data and physical and mental health. So that was just to set the stage. Oh, and then just to look a little bit closer, I did look at a few issues around alcohol and mental health that we can get by the service area. And I just find your service area based on basically Jefferson Healthcare's primary service area, where most of their patients come from, because we had those zip codes. So this drills it down a little bit further to show how your immediate service area is doing on some of these factors. This is in the behavioral risk factor surveillance system, and it's self-reporting. And so actually in some ways, mental health, except for the self-reporting days of poor mental health days, you were doing better than the county and on a lot of those indicators and state. You can see that alcohol consumption, heavy drinking are two issues that seem to be worse in Jefferson County than Washington State, but I just thought that was an interesting look. And again, these are self-reported numbers. I did take 5 years because the numbers get so small as you start getting at the zip code levels. So I combined all the zip codes in your service area and 5 years of data so that it was hopefully not skewed too much by the small numbers. So that's just, did you have a question?
Yeah, I had a question. Could you go back to, what's the difference between service area and Jefferson County?
So service area is the zip codes. So I was trying to drill down more on the Port Townsend, like where your service area. So I took Jefferson Healthcare's top zip codes. So patient origin, basically, where their top patients come from. And I used those zip codes to determine a smaller area of Jefferson County. So you could compare kind of your area around Jefferson Healthcare to the rest of the county.
Oh, okay. So
yeah,
it's still Jefferson County.
It is in Jefferson County. Yeah, all those zip codes are in Jefferson County. It's just that piece of Jefferson County I thought might be interesting. Yeah. Not that a lot of you don't serve the whole county in Jefferson County, but just that area around Port Townsend. I thought.
I wasn't sure if it was like on the peninsula or something like that.
Yeah. No, it's still within Jefferson County. I could give you those zip codes. I should have probably put them on there, but yeah.
I was just curious. Thanks.
Yeah,
I have a question too. Is it all right to ask a question?
Yeah.
So on the previous slide, I think it had like social organizations. I assume that's talking social associations. I assume that's really adult oriented. I've heard a lot of times people say that there's like not enough kid things to do, like in Port Townsend, Jefferson County. Is there a measure that tries to get at that?
That's interesting. I will look at, because it depends, I will look at the behavioral risk factor for surveillance system, say that 5 times fast. I'll look at that and see, because there are some, that's not counting health rankings, but there are some directed specifically at youth. And there also is the youth survey, the Washington State Youth Survey. I may have some questions like that. So that would be interesting to look at. That is one thing I thought about doing, and that might be interesting for next time, is to look at some of the youth survey results for your area and school districts, because they do ask quite a few questions that are related to these. So it'd be interesting.
Lisa, I think the Healthy Youth Survey does have some questions around social associations. So that might be worth looking at.
Yeah, so maybe we can do that for next time. That'd be an interesting. And I know that sometimes the behavioral risk factors surveillance system targets youth and on some questions. I'm just not sure which ones. So I can look at both of those.
Great, thanks.
Yeah. So that was just kind of an overview, set the context that, yeah, you guys are all on the right page. We have some, it is true that these things impact health, and I know you all know that, but I just think it was kind of an interesting way to start this discussion as we look at some of the data. So Lori, if you want to go to the next slide. So we, again, and a lot of you have heard this because I've been on the phone with you, but the data just really continues to show different emphasis between behavioral health and SUD, depending on the entity reporting. And so one of the questions, and we did this largely and when we were focusing on, do we want to do a crisis stabilization center? What are the kinds of services? We started thinking about, is there a reason to need to know? Is it more a mental health or SUD? And so it continues to be an interesting question. So clearly the mental health seems to be the biggest issue for Jefferson Healthcare and East Jefferson Fire and Rescue, which we know have a lot of duplication. So a lot of those patients are the same. When we look at the data, continuously is 80% or more of the behavioral health issues they deal with in their ED or in their responses are mental health. And in the Jefferson County Sheriff's Office, it seems to be kind of a 50-50 mental health and SUD. And then when you get to Port Townsend, it becomes much more of a issue related with mental health. And so it's just been interesting to look at the different numbers. And then when you get to the jail, it's SUD. And so you know that some of these people are going to each of these places. And so you can see, I think only 21% of the jail bookings code as mental health. And so, but the vast majority are SUD, and the assessments that are done on those inmates are almost exclusively resulting in inpatient or in SUD referrals. And so it's just interesting to look at the different buckets. And it's one of the things we're trying to get our arms around as we move forward in how we code these things, how we report them is, how are they being analyzed and how are they being coded? And we'll talk about that as we get into more of these slides. So I don't know if you want to go to the next one, Lori. If anyone's, I can't see everybody, Lori, so holler if anyone's trying to get my attention. And these next slides are really just more about that. They're just showing the difference. So Jefferson Healthcare, 82% mental health. East Jefferson Fire Rescue is 79% mental health. And I can talk a little bit more as we get further along about how people are put in these buckets. And I'll just start. One example is East Jefferson Fire and Rescue. They pick the top issue of the day. And I know I'm not saying that right. So if anyone's on from East Jefferson, that's how I remember what they said. But so it's, if they're coming out for an overdose, then they're going to be coded for opioid overdose. They're coded as opioid related that day and nothing else. So even if they have been drinking as well, or they are known to have a mental health issue, they are only coded as opioid. And whereas some other people, they may code one person that comes out in 3 different categories. And so that's just an interesting. So the the mental health is clearly the top issue of the day for Jefferson, East Jefferson Fire Rescue when they come out. So next slide. And then when you look at the Jefferson County Jail bookings, again, it's only 21% are mental health, and the rest of them are SUD. And Jefferson County Sheriff is really more of a 50-50. It's more mental health if you break it into the 3 buckets by far, but if you combine drugs and narcotics with alcohol, it's pretty much split down the middle. Next slide. And then 80% of Port Townsend police have a mental health component. Now with the Port Townsend police, they do mix them. And so you can see there's a had been drinking mental health, had been drinking drugs. So when you put all of those together and you count any that had mental health, it's 80% that end up with a mental health condition. Some of those have also drugs and alcohol involved, but definitely a more focus on mental health. And then this is data from Believe in Recovery, Gateway to Freedom. They do the assessments on inmates, and you can see as far as the assessments and recommendations for treatment, 88% of the inmates assessed are recommended to go to inpatient treatment. And then there's duplication. So on the right, this other bar chart is the same inmates and other referrals that they make. And this again goes back to some of these issues we were just talking about around socioeconomic needs. Is 54% need transportation, 76% are referred to MAT, 63% are referred to OLICAP, 50% of those that are going on to, that have been recommended for inpatient SUD also are being referred for mental health. And then DSHS, whether it's insurance or other issues that they need are referred there. So you can see kind of the breadth of issues that that population is dealing with, which I'm sure is no surprise, but interesting to me. And then this is Discovery Behavioral Health. Clearly, the majority of their issues, which makes sense, are mental health. They do have about 20% of the people that come in for an ITA investigation that don't get involuntarily detained end up being referred to SUD. The rest of them are crisis triage, inpatient mental health, et cetera. So it's interesting, which makes sense. And then I thought this was very interesting. Brian Richardson gave me some great data on kind of the issues facing the people that they have in their recovery cafe. And unfortunately, that program has been impacted by COVID, but it sounds like they're doing a phenomenal job is still being able to move forward and get people in the program. And they do a baseline survey. And you can see based on that, when you look down this side on the right, all of the things that these people are facing that are impacting their need for recovery and services to the Recovery Cafe. I thought it was pretty interesting mix of issues. So that's just, again, alcohol, substance use are top, but there's a lot of other issues that people are facing that they're helping with. And I just thought that was really interesting. So those were kind of just set the tone for the data and the mix. And again, and I'm trying to go fast because I know it's already 3:40. Again, it's the issues about how we, what do we do with all this data? And so some of the questions I asked people is, how do you know, how do you put people into buckets? What kind of assessment tools do you need? If you're more mental health than SUD, do you think that's accurate, or is it because of how you're coding it and what your focus is, whether it's legal versus medical, and so these are some of the responses that we got. For some reason, I can't see the whole, there we go. Some of the responses we got from some first responder screenings, I just kind of rolled them up. So I talked about a little bit about this already, that some people were saying, what is the issue that raises to the top that day? That's what they code. So if it's mental health, then mental health is how that patient's coded. And then the other thing was, how do you know if it is a mental health issue? And or a substance use issue? Is it need to be, you know, some kind of evidence or a long-term issue? And really it was what, if on that day they're having an acute anxiety, then they are coded as mental health. So, or if that day they are drunk when they come, then they're counted as SUDs. So it was a lot of it was just really what they're seeing when they get there. And then trying to follow up on some of these questions around how do you decide, boy, there's a first responder right out my door. How do you decide if to figure out if there's co-occurring issues? How do you decide that? And so, sorry, I can't see there we go. So how do you decide that? And so there was a combination of measures, and this was interesting to me too, because my gut was to try to get people like, oh, can you do an assessment? Can you figure this out? And really it's, people are in crisis. And so you have to use the tools you have and the information you have while they're in crisis, and not expect that you'll be able to do like a very detailed assessment. And so some of the combination measures, breathalyzer, self-reporting, first responder judgment. And then again, just this idea that there's a challenge to be able to really get an accurate screen and some kind of standardized responses when you're dealing with people in crisis, which completely makes sense once it was said to me. But so there's that. And then again, this just goes into more detail, and I'm going to go over this quick, and I think that we'll have continued conversations about this, but these were just some of the ways people were put into one of the buckets. And so for SUD, there was things like, you know, they've been drinking. That's it, that we could tell. They were currently on drugs. They were having an overdose. Obviously, that puts them in the SUD bucket. A lot of it was just their first responder could see that was an issue. There was evidence of drug possession. There's just those kinds of things, lots of different ways. Mental health, it was similar. There was, if they're upset emotionally, then they're coded as mental health. If they are exhibiting violence or currently showing signs of anxiety. And there was an effort among many of the first responders to try to drill down on also self-reporting. You know, how often have you drank in the last 30 days? Have you been diagnosed with anxiety or depression? Things like that. So it was a combination of things for sure. So one of the things that started us down this path was, and Lori, I can't see, if you just shout out if you need me to stop or if anyone has questions. So
far, I don't see anybody,
okay.
but if you do,
Trying
just
to
raise
be
your hand.
respectful of time, because I know you have more on the agenda. So I'm going fast, but I am happy to stop if anyone has questions. Screening tools. One of the things we were trying to get our arms around again is what counts as a screening as we try to do this information for HRSA. And so there's just clearly not again, based some on just the reality of being able to screen out in the field, things like that. But there was a variety of tools used and not consistency across the board, and very different, of course, if you're talking about official assessments in the jail or the ED versus on the field. So definitely the answer was there's not a consistent screening tool used, but I think in my mind, and it'd be interesting to hear others' feedback as we continue to talk about this, all these people are being screened at some level. And so as we are counting how many people we're touching and screening, I think they all count. I mean, it's, you know, you look at some of those things, it's important information to have. So anyway, I just thought that was interesting. And
I guess I had a comment on that. Since we started doing this, that's something that's always kind of, I wouldn't say bothered me, but, you know, just the idea of how accurate is our data. And I have this dream of that someone comes up with some kind of formula and a number you multiply it by that gives you the true amount. But by the same token, you know, I mean, I'm not a statistician, but if that would even be the right focus, but I don't know what other way you could do it.
Yeah.
I guess the idea that we just keep trying to do better.
Yeah.
Troy.
Hi, this is Troy from the police department. One of the things we have our system set up where we can have multiple clearance codes, and that's why we're able to have a mental health call to include alcohol or some kind of bucks charge. It's just, it works out better for our navigator to have that exact information. I believe he needs it for his records, and we need that for our tracking.
Yeah, yeah. So I think next slide. So challenges with standardization as far as being able to make sure that we all are seeing and reviewing things the same way. And these are challenges that you all raised as far as in our interviews. And one is different training and skill levels. Like not everybody feels comfortable in being able to do some of these assessments and be super confident that they're diagnosing someone correctly. Different focus. So if someone's in crisis again, and your focus is on what is their medical issue versus, what's the legal issues and what are the legal requirements. Also very different standards as far as, if you're looking at the ITA, the legal issues around an ITA investigation versus figuring out what someone's medical or clinical need is that day. Screening people in crisis, again, that was shouldn't have been, but was a very big aha moment for me, who wishes everybody could, get these really great assessments in the field as, people are in crisis. And that's just not necessarily the moment when you can get a really clear and accurate data from them. Time, that was raised too, is that even a 5-minute assessment is maybe just not always reasonable. And so just the time restraints people have on themselves when they are in these kind of first responding positions and situations. And then another thing was the willingness to comply. This was raised a couple of times. Is one of the challenges is just that individuals with substance use and mental health issues, there's times they just are not willing to comply either with assessments or with treatment. And so that there's this feeling of, there's not always a solution to some of that. That also came up around the duplication, is trying to get your arms around how many people, it's the same person over and over. And how important is that to get our arms around, because those are people that lack that willingness to comply, and how do they need to be addressed differently? So those were some of the challenges people found with standardization, because for obvious reasons, they just continue to. And then this was just something you may all know. I was just curious as we move forward on some of this to find out, like, what do people see as the biggest needs, concerns in the community? And I think that there was this three things really came out the strongest for me. Was one is making sure there's a continuum of mental health and SUD services and supports. And there was kind of two conversations around that. One is, this whole issue, are we big enough? Can we support services here? And there was a sense that we don't need to limit ourselves to that, that if it's accessible to communities statewide, that it, there was an understanding that behavioral health and mental health sometimes, especially with SUD, you maybe aren't in your community, or maybe someone would come from another community. So not to limit ourselves on, on some of that feeling like it either had to be local or that it had to only be supported locally. I thought that was interesting, but that people need to have the access to the continuum of mental health and SUD services, but almost as importantly as support for social determinants of health. And you saw that in some of those numbers about, housing, transportation as being one of the biggest issues that people are making referrals for. So just making sure that we have those social supports for social determinants of health. And then another interesting thing, and then I will let you guys just look at these because I'm taking up all the time, was the equity and access to services. And I thought that was interesting. At least 2 or 3 people said that they felt like COVID had impacted equity because, when you're doing services now online, if you don't have an ability to get online, then you're not getting those services. And so the concern with how this has impacted inequities or ability to have an equal system across all these services for everybody is a concern with COVID. And I thought that was valid and interesting to hear. So those were kind of, there's more on there, but I'm taking up too much time again. So the discussion for today, and I think it's just a starting discussion, John, and you can jump in, and Lori, I think if you'll go to the next slide, Lori, was, a couple things is what are the opportunities for establishing a baseline and doing ongoing data. We talked about, should we do some kind of baseline survey so that we can know where we are and then be able to measure it. And then this issue around continuing to gather data from all of you. And so we have now, I think almost from everybody, a pretty good chunk of data that we now are getting every quarter pretty routinely. And so that gives us a baseline and we can continue to measure. But then there's all these questions within that data based on all the things that we just went over about standardization and are there other elements that we need to be collecting both for HRSA and for yourselves to understand some of this data more. I know that HRSA likes to know insurance status of the people that are being screened. They like to know the race and ethnicity. I talked to some of you about that. It seemed like particularly on the healthcare provider side, we could probably get some of that data, trickier on the first responder side. So, and then what else is missing from that data? And is there a possibility to do some standardization? One of the things, again, examples was, is there a way to move from, if you're currently capturing just the top issue of the day, is there a way to standardize that we're all going to try to at least, see if there's co-occurring disorders, or are we going to really try to take the top bucket of the day across the board? How, in what ways could we do some standardization about how we're collecting this data? And is that important? So that was kind of a discussion point. And then survey data wise, I think, Lori, do we have some stuff on the next slide? I think about that. Oh, just being able to understand, and we're probably out of time for this today, but understand what you all know about what surveys currently exist. And, we don't want to be duplicative, but we really, there are some things specific to the services the grant is supporting and that you're all doing that would be really nice to be able to get a good baseline measure. I picked some questions from some other types of surveys, just as an example of questions are asking community members, first responders, and some questions being asked of patients and members, and just as some ideas of the kinds of things we'd like to get our arms around. So Lori and John, I took up too much time. So if there's anything else you want me to touch on, anything?
We are really grateful that you have put all this together, because I think even if we just barely start a conversation today, it provides a baseline that we've got all of this that we're looking at together to have the conversation. And John, if we were to summarize sort of the top couple of things that we might discuss at the next meeting based on what we're seeing here.
Yeah, I think we would probably want to center around that issue of standardization and whether it's possible to do that. One option might be to get just the data group together, either in a special meeting or as a replacement for one of these meetings to really delve a little deeper into the data, because not all of you provide us data. So I think standardization and then understanding the landscape around surveys, kind of where we are and what we might want to ask in terms of surveys. Those would be, to me, the top two questions for us to get some more information about.
So having said that we plan on having this follow-on conversation and sort of holding that in your knowing, is there anything that you want to ask or that you kind of raise your eyebrows at what you've seen here? Or is there any data that's your data that you're thinking, well, I didn't think that's what it said, that you could highlight for us so that we can sort of move to answer those questions or at least put them into the discussion going forward?
You guys from OLICAP perspective, we collect, depending on what program they're in, we have to collect all sorts of things based on the grant. And so, that's sometimes tedious and hard for our data, right? Because it doesn't always make sense. So that's something we're working on in-house here, because I feel pretty strongly about, data and things like that, and getting a sense of, for some of these folks, how long have they been living in transitional or homeless housing, you know, and how many of them are utilizing some form of social service. I mean, some places are using OLICAP and Recovery Cafe and St. Vincent de Paul, you know, and I think that's interesting when we talk about what services people receive that keep them from falling further into not having their basic needs met or falling deeper into poverty. So just thinking about, you know, those types of things when they come to our customers and what that could mean as far as, you know, what services we're trying to provide, and being able to make that case to our grantors, right? And so that's why the data is so important to us is, you know, if we see a void in the community, if we need more navigators or this or that, you know, being able to show the data of, you know, what is going on there is crucial. So, so I'm grateful to you all for, you know, the work and effort that everyone puts into this to try and get these numbers out there. Is really important. And I know with OCH, you know, I sit on that board and we've gone back and forth about trying to find, you know, a program where we all would be sharing information. And, you know, so many of the medical people, you know, because they worry too much, well, I say they worry too much, but right, I speak as a, yeah, as someone who, yeah, doesn't necessarily worry about, you know, somebody coming back and trying to sue based on one of these things. It would be so good to have, you know, information on some of our customers, you know, when did they get out of the hospital, or, you know, where were they last living? And for you all to know, you know, like if we're providing them services or money, or they're housed with us currently, you know, all the things that when someone is in crisis, they struggle to remember or know, you know, their information about who their caseworker is, or where they're living, or why they got kicked out of the last place. So that's tough because, you know, we'll get repeated calls about some of the same folks, right? And it's like, okay, here's the issue. This is why this person, you know, is no longer under our services. And so I think it's unfortunate that some of the laws regarding, you know, privacy and things of that nature are actually keeping us from being able to have good coordinated efforts amongst our organizations. I mean, I certainly understand wanting to, you know, respect someone's privacy, but by the same token, you know, my opinion is when somebody is also taking of social services and costing the community money to some degree, right? I feel like, you know, there has to be something that's done, you know, to help with those services, and being able to share that information is important. So we've looked at some providers, you know, who have different, you know, database systems, and I think some really great programs if we could get, you know, the agencies to be able to use them. So
that idea of being able to create a holistic picture of our client is something that we talk about. We've talked about a great deal as we were building the strategy before. It's a good portion of 2 projects that we as a consortium are looking at, although they probably won't start until next spring, summer time frame. One is a Friendly Faces program where we would, where our desire is to come up with some way that we can share information in a way that's legal and allows us to speak with each other on behalf of our client to make sure we're not losing them in the cracks, or that we have that understanding to get them to the next place with the right bit of information for the provider. Anyone else? One of the things that was mentioned was about discovering what other data sources are out there. And we have, you know, we know that OCH pulls together data, some of which is interesting to us. The Behavioral Health Advisory Committee, the 1/10% folks, they have some data. I'm trying to think, there are a couple of others. I just heard that, you know, from Jake Davidson's presentation that the hospital was pulling together some basic measures for the Ames grant, which I think would be interesting to know. Just so as we are setting our own baseline, and I keep saying at the beginning of the grant, but it came in September, so we're already in December, so we've got to hurry up and do something that is baseline. Our desire is to create a baseline so that as we get into a year from now, and then as we start to push to raise more money or to, you know, apply for more grants, however it is we're going to do that, we've got the data that shows, listen, we've made good use of the money that you guys have given us. This is how we used it. This is what change we see or don't see, and get them all motivated to, of course, give us more funding. So I would really call for those who have an awareness of surveys that are already being done or that are already out there, go ahead and just send it to me or Lisa or John, and we'll make sure to get that into the mix of what we're looking at as we try to set up something. And both Lisa and John are they're very good advocates on your behalf that any type of survey we do needs to be, you know, not long and something doable. So believe me when we say we're keeping that in mind. We have a great awareness that we're very lucky you guys do all of the work that you do to give us the data that you do. So we want to make it as streamlined as we can going forward. John, did you have anything you wanted to add there?
No, I mean, it's after 4, so we probably should just kind of do a little wrap up.
So I'm going to just tell you what's here. You'll see an overview of sort of what's going on grant-wise. This is just sort of operationally, action-wise, what's going on for every one of our strategic projects that we've got going. There's 9 of them. I've tried to just throw a bunch of stuff on a slide that if you called me and asked me about it, I could take you through if there's something specific that you're interested in knowing. So that's all of the strategic action plans that we're executing between meetings. And then just letting you all know that the RCORP grant from the planning grant that we had before this one is utterly and completely done. We've been giving presentations of the new grant to all of those folks you see there. We're really working hard to get contracts done so that money is going out to everybody. Recovery Cafe and HPFD, their contracts have been completed. Lots of presentations that we're giving, seems like every day we're giving another one. I just include these 2 slides because they give a list of all of the things that we're working on with this grant, specific projects here in our county, and then the model that shows where the number by each strategy actually impacts here on the whole system that we're trying to make sure is robust behavioral health wise here in Jefferson County. Letting you know that the website has been updated. So there's a historical page for the old grant, and there's an updated page with precious little information, but there's going to be more on it here in the next month. And then John, did you have anything you wanted to highlight quick about John Chip?
Yeah, really quickly, just a reminder that we have asked that the working age band group grow out of this team. And so if you are interested in participating in that, and I'd encourage you to do that, I think it's going to be really interesting work. It's about establishing priorities for working age health improvement in our community. If you have an interest, please contact Lori or me by next Friday. And we're hoping at least a few of you will join us for that session. We're likely to do that as kind of either a pre or post meeting with this meeting. So it's a little longer, but you know, would be the same day as this meeting.
And then just a reminder, and it sounds like most of you have gotten this data to Lisa, where we've moved ourselves so that we're on the same cadence of collecting our data as HRSA is asking it from us. And so this that we're collecting by December 15th goes from the beginning of the grant in September to November 30th. And so you'll get us that data by the 15th, and then we'll talk about it at the next meeting as well as ongoing. And then I just want to tell you all, it's the end of the year. If 2020 was a group math problem, who do you want on your team to figure out how many cantaloupes it would take to reshingle your roof if you're paddling down the creek at 2 miles an hour? and your kayak has lost a wheel, it's all of you guys. I definitely want you on my team. So that is all we've got. Anything from anyone? Thank you for staying an extra 5 minutes with us. Welcome feedback from anyone. Otherwise, have a great afternoon.
See you, everybody.
Bye.
Thanks, everyone.